Hello, welcome everybody to the No Normal Show for Thursday, July 30th, 2020, brought to you by Revive Health. This is our weekly deep dive into how hospital and health system marketers can navigate what we call the no normal. I'm Chris Bevelo, Health Systems Practice Lead at Revive Health and your host for the show. I'm joined by Chase Kleckner, who's Senior Marketing Manager at Revive Health and our show's producer. Hello, Chase.
Hey, Chris. Good to see you as always.
We're also joined today by Michiko Tanabe. Michiko is the Chief Marketing Officer for Stanford Health Care. As Stanford Health Care increases its footprint, her role continues to evolve, now including marketing efforts for the Stanford University School of Medicine. Michiko has extensive marketing communications experience working for global organizations featuring wide-ranging medical product portfolios. Hello, Michiko.
Hello, Chris. Wow, what an introduction. Thank you.
Yes, and did I get your last name right? I apologize profusely as someone whose last name is Bevelo. I get how that goes, but good. Okay, so joining us, we got a lot to dive into. We'll get to that in a second. Just some notes up front for folks. If you're new to the podcast, what do we mean by the no normal? Obviously, we're in the middle of a once in a century kind of situation with COVID-19, the impact on the healthcare industry plus our society writ large. People talk anxiously about getting back to normal or what the new normal will look like. Our point of view is, in reality, we have no idea what normal is going to look like, or even when we'll be able to say we're back to a normal or we see a normal. So for us, the truth is we're living in a no normal environment. And in terms of healthcare, it may take months or maybe even a couple years before we're ready to look at things with certainty again. So that said, we can't let that stop us from moving forward. We have to live with and succeed in an era of uncertainty. So that's what this show is all about. How are we going to do that as hospital and health system marketers and communicators? If you want to know more about our perspective on the no normal and the principles we believe health system marketers should follow, check out our blog post. Chase will post links to that in the chat section of Zoom. So if you would like to engage with Michiko or myself or Chase as we go through the show, please put your questions in the Q&A queue in Zoom. You can use chat to talk to other participants. Again, Chase will be putting links in there as we refer to things if you want to see those. So use the chat function for those purposes. But if you would like us to answer a question, make sure it ends up in that Q&A queue. And remember, this is a podcast. It's live right now, but we will both post a recording of the show on our website by the end of today. So you can find that at thinkrevivehealth.com/COVID-19, or you can subscribe to the audio podcast on iTunes or wherever you listen to podcasts. And I think that's it, Michiko. We just want to dive in with you because we're so glad you're here. We're so glad that we have Stanford Health Care with us as well. So let's just start because obviously things are happening in California right now, unfortunately, that are not what we would want. Maybe you could start by just kind of painting a picture of where things are at in your states, where they've kind of come to over the last, well, I guess you've been dealing with this at some level all the way from the beginning, but certainly over the past few weeks or month, it's not gotten better, if gotten worse.
Yeah, thanks, Chris. It has gotten worse, sadly. And we've been dealing with this for what seems forever. You know, Governor Newsom, we were the first to go, or one of the first to go to shelter in place, and we did flatten, and we saw what needed to happen based on what he had done for us. He had a really good plan, though, a phased approach to open. And I can only best talk about Northern California, where I reside, as opposed to, you know, California's a big state. There's a lot going on in Southern California as well. But in Northern California and by county, it ebbs and flows, but there is a resurgence, right? We're not talking about the second wave. We are calling it a resurgence of COVID-19 cases. We at the hospital here see an uptick of inpatients as well as those that are on our ICU floor and on ventilators. more so than we did back in March, April, and May. We took a break, if you can call it that, May, June timeframe. And when I say we, it's really the ops team. But I would say if there is good news, which there really isn't good news, we've learned from March, April, May. And our playbook that we had, dusted it off for this pandemic, and now we've learned and we can coexist with COVID-19. So like many hospitals, we resumed care. The delayed elective surgical cases, we opened back up on May 4th and have been going strong. We see that it's coming back, and it's coming back strong. We'd like it to be stronger because we don't want patients to delay their care. But we know how to live with COVID-19, sadly, but allow patients to get the care that they need. And I think part of it is, honestly, as a resident here, I'm going to get on my soapbox and talk about universal masking, hand hygiene, and social distancing. Because just in my going back and forth in the hospital, so I go through downtown Palo Alto, I go through other places, there's not enough people masked.
Yeah.
There's not enough people socially distanced. And we know, right? The evidence says that. You need to be distanced. You need to be masked. There's a lot of studies out there already, right? So from a marketing perspective, that's what we're talking about. There's not this deep, rich content, although we have that. It's basics right now because we don't know what's going to happen. Every time Governor Newsom comes out with his daily newscast, it's grim. It's really, really grim. And we are fortunate that go ahead.
No, go ahead.
No, well, we're fortunate that we're on his task force. Like we have faculty on his task force and helping to steer and drive that and talk about testing and a few other things. But
so it is curious. I think back to early on in this. We started a daily podcast like the third week in March, and I think it was maybe the first week in April. We had the CMO from UCLA Health on, and I remember remarking like, at that time it was New York, New Jersey, Detroit, New Orleans. And I remember expressing, how surprising it was that given the size of LA, given that the outbreak had actually occurred first on the West Coast, as far as we knew at the time, that we didn't hear much about LA, that it was, doing fine. And California has gotten credit for really, like you said, starting the first to lock down, really doing things the right way. And then we saw this resurgence over the past month, and the states that were most talked about were Florida, Texas, Arizona, and California. And California really sticks out among those because the other states kind of notoriously opened up probably way too soon, way too aggressively, didn't really follow the CDC guidelines on waiting 14 days of straight, case drops and all that kind of stuff. But California wasn't really in that boat. So what do you think is going on? Does it go back to just the kind of the masking and the basics and people just losing their discipline, or how is California in that group of folks, even though it seemed to have taken the right path the whole way?
I think it's a combination of all of that, right? And so there's so many counties. Again, California's a big state, lots of counties. And so as a state, we shut down, but then we opened up county by county. Mm. And so every county has different regulations put forth by, Governor Newsom, but depending on where you were, phase 1, 2, 3, or 4. And so I can drive a mile now and be in a different county and actually go to a gym. In my county where I live, the gyms are still closed, right?
Yeah.
So I think there's a little bit of that. People have cabin fever, right? It's hard to be shelter in place. So people are driving. I've noticed, traffic in California is a nightmare anyway, but there are more cars out. And I think people are driving to get to where they need to go. I think the other thing is that it is going back to that masking and socially distancing, and what does that really mean? And I will say the counties have done a great job, though. When I look around and see the streets that have been closed off so that outdoor dining can take place, there are tables out in the streets. Like it's a street fair every day in the big streets. It's a street fair, right? Because we need people to be out. But if you're responsible about it, you need to be responsible. And so I think part of it is county by county, and now you just see it. This county can do this, that county, and it's changing. And so there's new rules and regulations about being on the hot list, being on the watch list, what it means, and they are looking for consistency across. But again, it's such a big state, it's really hard to do.
I don't even know this. Has Governor Newsom issued a mask mandate in California statewide?
Yeah.
Okay.
Yeah.
Okay.
So he was one of the first, and
yeah, it's crazy. And then we think about, we're moving into schools. Of course, that's a whole big other issue. We don't need to get into it, but just countrywide, everybody going back to school. My daughter's trying to get back to college. That's a whole nother story. Maybe we'll get into that a little bit when we talk about our next topic. But it's a little worrisome that we're about ready as a country to go through this whole new wave of activity of schools to whatever degree and what that may mean. So it's unfortunate that we're in this situation, and it seems to have plateaued nationally. Obviously, it depends on what state. I think I heard today that Texas and Arizona are finally starting to do a little bit of this, but Florida and California are still not going in the right direction. So, and now the Midwest, which is where I'm located, and Chase is in Tennessee. Tennessee is not a poster child for how this should go.
No.
It's not doing well. So anyway, it's not good. Let's talk about testing, because I know Stanford has done some things with testing that put it out front. Why don't you kind of give folks the background on what you all did with testing and what you're doing now?
Yeah, so we're very fortunate as one of the first AMCs to develop our own testing and be able to get out there quickly. And so with that, I think to date we've tested and helped to test over 100,000 folks, as well as doing the over 25,000 of the serology testing. Those are the antibody tests. And I think what's unique about us from a marketing communications perspective and even a strategy perspective, we are an integrated group. So there's a chief strategy officer over all entities. So that's the Children's Hospital, the Adult Hospital, and the School of Medicine. Marketing and communications spans School of Medicine and the Adult Hospital. So I have marketing, and then I co-lead or have oversight with a partner who's got communications as well. And so we're able to talk about the testing and what's happening, because that really came from the research aspect of things and moved over to clinical care delivery. And because we were able to develop that testing first and get that out the gate, we were able to help other hospitals, right? This is when you come together. There is no competition. There is none of that. You become a family and a unit. So, we helped 14 other hospitals get their testing stood up, or took their lab tests in when needed. When they were able to stand up their own testing, we went to first responders, essential healthcare workers, to make sure that everybody was getting tested, because my guess is your daughter might be having trouble getting a test because she's asymptomatic.
Don't get me started.
Right.
It's been crazy. It's been crazy. Yeah.
Yeah. And so we stood up drive-through testing right away.
Great.
And the abundance of, the overflow of folks coming through, but it was also really scary and daunting. And so from a messaging perspective, whether it was communications or marketing, it was really important for us to give visual cues of it's mostly contactless testing, right? You take a picture of your driver's license, you scan, you email it in, you scan it in. The only contact was the actual test itself. The nasal swab, you can't do it yourself, although.
And it's like a 3-foot swab. So you're a long way away. I've been through it twice. So I know that you could be a distance and still get that thing done.
Absolutely. And, we were fortunate enough to open up our a new hospital, a new building, a new hospital last November. And so it was what we call design to adapt. And so we converted, the ED was converted into drive-through testing. And that was what it was meant to do, not drive-through testing, but really be there for us in a crisis situation. And then throughout the Bay Area, as well as throughout other parts of the Bay Area, we were able to stand up that drive-through testing. And it still remains today.
What's the status of testing?
We see that resurgence
today. Yeah. So like availability of tests, not just for Stanford, though you can speak to that, but overall, and then the results, because we've been hearing kind of nationally, like, things are backlogged 10 to 14 days to get results, which kind of defeats the point of doing a test if that's to like find out who has it, quarantine them, all that kind of stuff. So what's the state of that in your area?
So at Stanford, again, we're really lucky because we do our own testing. So we have our own lab, and that's how we were able to get it through so fast.
Yeah.
Right. So it can range anywhere from 2 hours to 2 days, depending on where we are. We are ensuring that every patient that comes in for a procedure is tested. We've also allowed for those that are traveling. Again, California is a big state, so we get folks coming in, long distance driving. So we have a partnership with a hotel, a local hotel, and those hotel folks are tested on a regular basis. So patients feel safe, like, because it's daunting out there. You don't know what you don't know, and it's scary, right? But we have that, and now we were just FDA cleared to do pooled testing. So our goal is to be able to get 20,000 tests through a day.
Wow, that's great.
We have, invested in the equipment. It's all been calibrated, and the ops team is working fast and furiously to push that through.
Well, I wish I lived by you.
Resources.
Yes, I wish I lived by you. Wait, I mentioned my daughter, and I will share that like she works at a food chain. There was an outbreak. Over the last couple of days, we've learned that she's been exposed now to 2 different people who have tested positive. So she had a shift with them. So she's getting tested as we speak, but we had to call around to multiple systems in our area, in the Twin Cities, because most of them are not issuing tests unless you're symptomatic. And she's not symptomatic, but clearly she needs to be tested given she worked with people who are positive, and she's trying to head back to college. So we kind of need to know before she drives to Montana, which is a haul, whether she's positive or not. And so it is so, we're in this business, right, Michiko? Like we study this, we're on top of it. But then when you personally have to deal with the idea that there aren't enough tests still to test the people who need to be tested, it is mind-boggling that we're still in that place in parts of the country, right? So I wish we lived by you guys and we could go in there and just get it done.
Well, and we don't have enough either here, I'll be honest, right? But we're getting there. We need to be able to make sure that we're also testing on a regular basis. I will also say, though, as we reopen, it's not just about testing, right? We need to look at contact tracing. We need to look at social, all of it. There needs to be a strategy. Testing is incredibly important, don't get me wrong, but it's not just about testing. There needs to be a full-blown strategy, which we are implementing here at Stanford, and making sure that our local community, our patients, and our employees are equally as important as our patients, right? You need to have healthy employees to take care of patients. Mm-hmm. So our patients are important, but our employees are equally as important to make sure that they're healthy to take care of patients.
Let's talk about, we've got a question for you, but I'm going to hold it because I think it's related to the second thing we want to dive into. And that's really, again, Stanford obviously has a world-respected brand, one of the top institutions in the country for sure. How are you leveraging that to help with this crisis in terms of information, providing trustworthy content that people, know that they can go to, and not just for maybe your area, but beyond that as well?
At the moment, we're focused really locally and regionally because we feel a responsibility to our local community. We are here for the community, and so it's inherent in our brand, right, that we are a credible source, we are a trusted source. So right now, from a marketing team perspective, the goal is use our wealth of content and our strong content and push that out on a frequent basis. And I'm not as concerned about the packaging of it, the wrapping of it, right? It's really about the content. What's there? What do we have to say? And the content that we push out just lends itself to that much more credibility. And that's starting with the testing and what we're doing for safety. We're not doing anything different than any other healthcare system is doing, honestly. But being the hospital for the community here, we need to share that and to visualize that, right? And so it's not even so much the words. We've got the videos to show and the photography to show how we're distancing. Our clinical workflow has slowed down, so it allows for that social distancing. So when you're registering, which is contactless, but there are some that can't register, on their iPhone or their mobile, they're coming in, and we make sure that there's not anybody else there. The hallways, all of that. So our clinical workflows have adjusted for that, and we're communicating that, we're sharing that. But we're also talking about, our world-class epidemiologists who are looking at this disease. It changes, the virus changes daily, it seems like. Like what we thought we knew in February, March, April has really changed, right? So we want our audiences to understand that we are trying to keep up with that, or we are keeping up with that and communicating on a regular basis. And so we've seen an increase on our website and just people coming back to understand what's fact, what's fiction, what are those myth busters, where can I go for testing, what should I do? I need to get care. I'm not a COVID patient, but whether it's my joint replacement or I have a chronic disease or I'm a diabetic, whatever it is, we want those patients to understand that we've created a very safe environment. And as a hospital, we've been able, and an academic medical center, we've been able to test all of our healthcare workers. And the incidence of positive cases is less than 0.5%.
That's great.
So I come to the office on a regular basis, and I feel safe coming to the office. There's no qualms about it whatsoever.
Well, let's talk about that for a second, because that gets to our question. And I'll remind folks, if you've got a question for Michiko or myself or Chase, put that in the Q&A queue. You can use the chat to talk with other people, but we are monitoring the Q&A queue specifically for questions. And I think I saw a question pop in, Chase. If you can copy and paste it into Q&A or somehow let me know so we can get to that one as well. But the question that came in earlier is related to what you were just talking about. So I'll just read it. It says, for patients seeking care, needing care, whether it's virtual or in person, what are patients reporting as the biggest barriers to access from what you guys are hearing? I can share a little bit from what we've seen as well.
So right now, we don't have an access challenge, right? COVID-19 wiped that out. We used to have a huge access challenge, but as a tertiary quaternary, we don't have that as much. Although we see, like I said before, our cases coming back, right? So elective surgical procedures, with the exception of cosmetic surgery, everything is back, and we are full bore. The barrier, honestly, is primarily the patient's own barrier. And their fear of coming in, right? So we see a lot of cancellations. So the ops team, along with our patient experience team, they're now, like everybody else, we have daily huddles. What are those pain points? What do we need to do? What do we need to resolve? So the patient coordinators are walking patients through, calling them, making sure they understand, alleviating the fear, sending out information in advance, contactless, and doing whatever they can. So at the moment, there is not a barrier except for a patient's own, which is real. You can't dismiss that. Right.
That's right. And we've been studying this since the outset. We've been doing national and local surveys and continue to see a level of fear in a certain segment of the population for coming back in. And we have heard from other systems what you just shared, Michiko, about volumes getting back, maybe not to 100% of where they were pre-COVID from a surgical standpoint, but 70, 80, 90%. But as we know, that's a gap that hospitals and health systems can't afford. They're not going to survive long-term at 90%. And so even if it's just 10% of the people, that's a lot. In addition to the fear of COVID, there's a couple of nuances. One is we also have to think about the economic challenges people are facing. That's a fear that people have expressed, that either they've lost insurance or they're really concerned or have lost their job and don't want to spend even $500 or $250 on a deductible or copay. And then also, it's one thing for people to come back in for hip surgery or for stroke care. But the concern, maybe even equal concern, is, well, I'd come back in for that, but I'm not going to come back in for my skin cancer annual check, or I'm not going to come back in for my physical, because why would I risk it for that? And obviously that upstream care, that diagnostic care, the preventive care, that is what eventually leads to the necessary surgical care. So if that upstream care is dampened, then we would see people missing, not because they are knowingly avoiding surgery, they just don't even know they need it because they haven't got the tests and the consults. So I think that's something else that we're seeing and hearing from systems, that fear of how do we get people in for the things that they're just waving off saying, I can wait 6 months for my annual checkup, when really, take that across 10,000 people, that's going to have an impact. Okay.
And I would say from a marketing perspective, communications perspective, though, that's what we're talking about, right? And we are using every channel possible to talk about why you shouldn't delay your care, even if you don't think, right? So as open enrollment comes, September comes, it's about going in and getting your annual physical. And there's ways to do that via telehealth. I know all of your other guests have talked about telehealth. We do the same thing, and we've seen the uptick, and it's amazing what a pandemic will do to be the forcing function to not prolong anything, and things can get done far faster than they used to get done, right?
Yeah.
So that's what I'm using it as, a forcing function.
Yeah, and that's so funny you use those terms, because we have another client that used that exact phrase, forcing function, and used it for virtual care. And I think we've heard remarkable, things that if you had told me before all this, I would say that's somebody's making that up, right? So it's like a large system going from 20 virtual visits a week, like a huge system, right? Not Stanford, but imagine at Stanford, 20 virtual visits a week in January to like 25,000 a week. I don't know what is more astounding, that it was only 20 before, or that it's 25,000 now. We're starting to see that kind of tick back down, because as things open back up, naturally most people would rather see their doctor. But I think there's going to be a permanent increase. I think we would agree there's going to be a permanent increase in virtual care, because once you've got a taste of that, like I had to do that, I'm like, why would I ever go back into my doctor unless I had to get something physically done? If it's a consult, I have type 2 diabetes, I don't need to go into the office. Why would I go wait 30 minutes in a doctor's office and read Golf Digest from 2012 when I can just sit? Even if I had to wait a half hour, I'm at home. I can do I can work. I can do all kinds of things. So I think that's going to be a huge shift for us all, for sure. The channels is a question that's come up a couple times. So what channels or digital strategies do you view as the best way to kind of connect with people? Is there anything that you can speak to that you've seen? You mentioned virtual care, but maybe from a marketing standpoint, that's having more success than others, or that's different maybe than what we might have seen pre-COVID?
I don't think it's anything different. We're doing what all other health systems are doing. We haven't found something, shiny and brand new. But one of the things that we have done are town halls, and that came from the executive communications group. And that my partner in crime for communications, she actually oversees all of that. But it is with our leaders, so the dean from the School of Medicine, as well as the 2 CEOs, and we have guests on every week and just talking about PPE or the vaccines or what's happening in research. And they're weekly town halls. They're only 30 minutes. And they were meant to be for our internal audiences, for employees, to let them know what's happening, as it was a communication channel. We opened it up to the public because what we were finding is nothing being said on the town hall was proprietary, confidential, any of that stuff. And the numbers for us are staggering in the tens of thousands, 8,000, 9,000. We hit 10,000 with Dr. Fauci because we were fortunate enough to have Dean Miner have a fireside chat. So we're very proud of that. And that was, again, the communications group. But the town halls probably, because they want to hear from the leaders. And they want to hear from supply chain. They want to hear from ops. They want to hear from patient experience. That's probably the only new channel that we've been using to be able to open up to the public, but there's nothing shiny and new, really.
That's a phenomenal idea, and I think we've heard of a couple systems trying to do that, but not to that degree, and I don't think with that success. And I would echo from other systems that we work with and have heard from. There's not necessarily anything new. It's mostly, of course, digital, but I think what is new is the frequency, and that's not driven just by the need, as you stated earlier, like this is changing and we need to make sure we're on top of it always, but also the demand. We have a famous set of books here called Joe Public Doesn't Care About Your Hospital, which isn't really true anymore, because people want to, the surveys we've done, people want to hear, first of all, from hospitals and doctors before anybody else. They trust that group before, the government, national healthcare experts, local government, insurance companies. We're at the top, and they want to hear daily. Like, when was the last time we would have run a survey and people said, yeah, I want to hear from my hospital every day, but they do. And so I think that's the thing that's changed probably the most across the board is the frequency. Though I would say not everybody is meeting that demand as well as they could from a hospital health system standpoint. But the need is there and the desire is there. So, okay, let's shift to the last topic we want to hit on. And it's kind of kind of depressing, but we have this thing called the seasonal flu.
Chris.
Yeah, we have the seasonal flu thing that's coming. Normally that I think officially starts in October. And I know when we talked, Michiko, kind of preparing for this, you guys have already begun planning for what's going to happen when the seasonal flu hits, because obviously COVID will not be gone by then. I don't think anybody expects that. You've got, in most cases, the seasonal flu that's going to have very similar, symptoms for COVID. It's going to, oftentimes this doesn't make the news, but the seasonal flu will run ICUs to capacity in normal years. Oftentimes there's ED diversions because of the flu. They won't let people in a particular ED, so they send them to a different hospital. Normally doesn't make the news, but that does happen. And so that's all going to be on top of COVID-19. So tell us kind of how you guys are approaching it, or what you're thinking, or what you've done to whatever degree you can, and thinking about that, certainty that's pending.
Yeah, so the ops team here is already are looking at the clinical workflows for those influenza-like illness symptoms, right? And what is that going to look like coming through our ED, or going to your primary care physician, telehealth visits, things like that? What does that look, and how does that triage happen? From a marketing perspective, what we're going to really hit home is the flu shot. Everybody should get a flu shot, because whatever you can do to mitigate that flu, and we don't know what the strain's going to look like, right? Every year the strain is very different, and you don't know when it hits. We are prepared for late September. The ops team says, the clinical folks always say, well, it doesn't really hit until November, but this is 2020 is a interesting year, right? So we just need to be prepared. So that's what's happening right now. And the ops team is looking at patient experience, is looking at how do they handle all those patients coming through, and what does it look like? And even to the visitor policy. So right now we have a very strict visitor policy, just like all other hospitals, right? And it fluctuates. Sometimes it's 2, sometimes it's 1, sometimes it's 0. What is it going to look like? And how do we make sure that we're doing right by patients, having their loved ones, but doing right by patients, making sure that it is a sterile environment as possible. And so that's really what we're looking at. We won't know until the flu strain comes out to say, oh, we can triage through our tents outside because that truly is the flu versus COVID-19. We hope to have our testing that much more ramped up so we can test quickly for COVID and, eliminate that, and it really is the flu, or take then those precautionary measures for the COVID patients. But communications will be about get your flu shot, get your flu shot, get your flu shot, and we will do it as contactless as possible. Unfortunately, that's not a telehealth visit.
No, that is true. It's just going to be one more curveball in a year of curveballs. It's kind of crazy. We have one more question up here that I want to get to you, Michiko. Question is, how are you working with your affiliated practices throughout the community beyond the hospital? Are you seeing any impact to those sites in terms of volumes or otherwise?
We only have, so our network, right? So we have a network of primary, secondary care practices, and they reopened up again as well in the May timeframe. And so they're booming with the telehealth visits, but secondary care still hurting a little bit. But I wouldn't say that we see correlation, right? So the faculty practices have ramped back up to good volumes. And so has our network, right? And then we have a hospital out in the Tri-Valley that those volumes haven't come back quite as robust, but it's also a different type of hospital. And so I would say that our communications and marketing efforts are a lot more intense in that area, but they're parallel paths and we don't treat them differently, honestly, from a marketing perspective.
That makes sense. That makes sense. All right. Well, I think that's a good place to wrap. Yeah. Anything else you want to add? Any last little bit of wisdom? No, you shared quite a bit. So thank you so much for being with us. By the way, we were going to give a shout out to our colleague, David Perry, who is your colleague at Stanford. I've known David for a long time. He wanted to be on the show with us and couldn't make it. So we'll drag him in sometime later. We'll make sure.
That'd be great.
Yeah.
He's a wealth of information and a wonderful senior advisor to have here at Stanford Medicine.
Yeah, absolutely. So just want to give him a shout out. But thank you so much for joining us, Michiko. That was fantastic.
Thank you so much. Appreciate it. Everybody stay safe and healthy.
Yeah, that's right. If there's something you want us to cover, let us know. Throw it in the chat channel. You can also email us at knownormal@thinkrevivehealth.com. If there's a guest you'd like us to try to bring in, any topics you'd like us to cover, let us know that. Chase, thank you for joining once again.
Absolutely. Thanks, Michiko, for joining us today.
Absolutely. My pleasure.
Remember, we'll post a recording of this video recording on our website, thinkrevivehealth.com/COVID-19 by the end of the day. It'll also be up on iTunes or wherever you subscribe. Come back to us next week. And until then, good luck out there in the no normal.